Greetings and a warm welcome to everyone. I am Trishna, your moderator from CLIRNET, and it is my pleasure to extend a heartfelt welcome to all the delegates joining us from across the country today. We are honored to have the support of highly esteemed doctors, and I sincerely thank each one of you for taking the time to be with us. So, before we begin, let me briefly introduce our platform ClearNet, one of the largest live digital continuing medical education platforms. ClearNet provides a global space for healthcare professionals to collaborate, create, and engage with medical content. It is my great privilege to welcome our distinguished speaker for today's session, Dr. Amitav Banerjee sir. With the degree of MD, he is an epidemiologist with a distinguished career in the armed forces, having served at AFMC Pune. He is currently Professor Emeritus in the Department of Community Medicine at D.Y. Patel Medical College, Pune. The topic for today's session is HPV vaccine in the UIP. Is it a sound move? And let me give you a brief on the topic before doctor can dive into the session. HPV vaccine in the Universal Immunization Program examines the inclusion of the human papillomavirus vaccine as part of a large scale public health initiative. The vaccine is designed to protect against HPV infection, a leading cause of cervical cancer and other related diseases. So, incorporating the HPV vaccine into the UIP aims to reduce the burden of HPV associated conditions through widespread immunization, particularly targeting adolescents before exposure to the virus. So, without any more delay, I now hand over the session to you, Doctor. Kindly proceed with the talk. Over to you, and thank you.
Thank you, Trishna. It's a pleasure to come on this platform and interact. And today is an important topic, HPV vaccine in the UIP. So I'll be raising some questions. Is it a sound move? As an epidemiologist, I would be just reviewing the data, whether we have adequate evidence and strong evidence, or what are the gaps in evidence rather, whether it justifies to be included in the public health program as such. So these would be the talking points. What are the risk factors of cervical cancer? We'll rapidly go through. And what is the incidence and trends in India? Because as a public health person, as an epidemiologist, when you decide any strategy for vaccination, you should have the disease trends. That also helps in monitoring the efficacy of the vaccine after its rollout. And what is the burden of disease? What is the natural history of the infection? Then what is the contribution of HPV as a risk factor for cervical cancer? Or is it the only risk factor, or there are other risk factors? Then what are the precancerous lesions and their course? The natural history of disease is also important when you consider any vaccination program. And here are the gaps we will discuss as we go along. Then what is the evidence on HPV vaccines? Then what are the certain past, there were certain misadventures during trials in the young girls, 9 to 14 years, where the vaccine is proposed to be introduced, or rather it has already introduced. And what are the gaps in evidence? And what should be the recommendations if we want to practice evidence-based public health? So these are talking points. So as you know, most of you may be aware, the multiple sex partners is the number one risk. And then poor genital hygiene. Women do not change the cloth, but now the standards are improving. Early age of marriage, again, this is also been taken care of by legal measures. Repeated pregnancies, again, this is also coming down. And the human papilloma virus. Human papilloma virus exists in such environment, in such as cofactors, because it's an infectious. The virus is infectious, so if you have multiple sex partners, the probability increases. So in our culture, and the rationale for introducing in 9 to 13 years is that before the sexual encounters occur. So we have to see the cultural background also. We have to have some surveys, behavioral surveys, whether we have such behavior in our teenagers, because this is uh, extrapolated from the Western culture, because there the teenagers become exploration. They have the sexual encounters early. So that also has to be taken in care. Then genital hygiene is improving. And as I said, these are the factors. So now coming to the incidence and trends, what is the burden? The cases of cervical cancer per 1 lakh women, it is 14.7. Globally also it is around 12. So India and global is not much difference. We have got lot of announcements that we have the largest burden of cervical cancer. It is because of the absolute numbers, because of a large population. So it's not something very extraordinary in our country. Death is 9.2 per 1 lakh. This is an important figure. That's why I have put it in red, because this is on this our policy depends. And we should remember this figure, around 9 per 1 lakh women die annually in India from cervical cancer. And for the past 3 decades, there has been a decline in incidence, more than 21%, and mortality has decreased more than 32%. And this is the paper I have given the reference, and I will be citing it at the end also. This is published in this is published, sorry, in BMC Public Health, BMC Cancer. So this paper says this particular paper has charted the trends of cervical cancer incidence and mortality. For the past 3 decades, it is falling down. So that baseline data is very important, because if we introduce a vaccine, even in natural course of disease, the cases are coming down because of increase better socioeconomic status, increase in personal hygiene. People are having protective sex, safe sex nowadays, because of the HIV and other STD fears. So all these factors has to be taken in consideration. And just to compare, we have almost 10 times higher deaths in normal pregnancy. Deaths due to childbirth in India are 97 per lakh population. If you see the deaths from cervical cancer is 9 per 1 lakh, whereas childbirth deaths are 97, almost 10 times more. Another thing of importance to see is that these childbirth deaths are in younger women, 18 years, 20 years, 25, 30 years, mostly teenage pregnancy. So we are losing 10 times more younger women during childbirth, which is a physiological, yeah, rather than 9 women, 1 lakh in older age group. This is important because this is again from the data which is available in the public domain. This is important because we lack the gynecological services, obstetrics and gyne, particularly in the rural areas, district hospitals and downwards. So if we have a good gynecological services, equitable distribution, we have better screening for cervical cancer. For cervical cancer, the best prevention is periodic screening by pap smear, and we don't have those services. And for that, we are having high rate of deaths during childbirth, maternal mortality rate, one of the highest in the world. So whereas the deaths in childbirth is 10 or 12, in the West, we are having 100, 10 times more. So we have priorities is there. Like this is not the number one problem, as the vaccine, HPV vaccine is not the number one problem for women. Childbirth is 10 times higher. Then other gaps is like the HPV vaccine which has been rolled out is by Serum Institute. It has got 4 serotypes only, quadrivalent. Whereas there are more than 150 to 200 strains of HPV. And due to vaccine pressure, it has been shown the other strains emerge, which are also carcinogenic, some of them like strain 58. So this is the gap, major gap. The 16 and 18 are considered more likely to be associated with cervical cancer. Others are 6 and 11. The quadrivalent HPV vaccine contains 16, 18, 6 and 11. But it has been seen that once under vaccine pressure, the other strains emerge. So this is the reason why it is not a foolproof prevention against cervical cancer, as the promoters try to make out. Because in spite of the vaccine, you require the screening, because there will be other factors are there. Other factors are there. Even without HPV infection, women get cervical cancer. So it is just one of the factors, and it how much attributable it is again depends on what is the prevalence of HPV infection in the population. In the general population who do not have the risk behavior, as majority of women in our culture, the prevalence is less than 2%, whereas in commercial sex workers, in people with HIV/AIDS, it is 50%. So the high risk group is more likely. So prevalence varies from 2%, and the chances of cervical cancer is very less if the HPV related cervical cancer is very less. Then high prevalence found patients with cancer. Then women living with AIDS, it is 54%. So if the prevalence of HPV is very less, if you give it to the general population, your benefit would be very marginal or hardly yet. And then there are other strains. So these are the gaps in literature. Other is the what is the natural history of the lesions, HPV infection. CIN is cervical intraepithelial neoplasia. After the HPV infection, there is some people have lesions related to the HPV virus, and these are supposed to be precancerous, but they do not all proceed to precancerous. So there are the three stages: cervical intraepithelial neoplasia 1, CIN1, CIN2, and CIN3. Most of the CIN1 and CIN2, they clear itself. Only the CIN3 progress to cervical cancer, more than 12%. They also all do not progress, only 12% progress. That means even CIN3, 90% will clear, whereas other CIN1, 99% will clear, and CIN2, 95% will clear. And what they have seen in the vaccine trials are these interim measures, antibody level, and clearance of early lesions. Because if you see the cervical, if you are giving the vaccine to children 9 to 13 years of age, cancer occurs median age is after 50 years. So you have to have a trial which have a follow-up period of 30 to 40 years. There is no time for that trial. So no study has seen the final endpoint. The final endpoint is cervical cancer. So we cannot say with conviction what is the efficacy, because we have taken interim measures, that is antibody level, and we have taken the clearance of early lesions, CIN1 and CIN2, which clears by themselves most of the time. One odd study is there for CIN3, and that attributable risk comes to almost marginal. Most of the studies, they give efficacy by relative risk. But when, as I said, if the prevalence of HP is very less, if the incidence is very less, 9 per 1 lakh, the attributable risk would be very, very minuscule of prevention. That is the actual judgment of vaccine efficacy in a public health program. So these are the other gaps. We do not know how well HPV vaccination protects against cervical cancer because of these gaps, because there are 150 to 200 strains. Trials have not followed right up to the 30 years endpoint. Trials have not focused on the outcome of cervical cancer. They have too few participants and did not follow up for long. Like the 2000, 3000 they have done, and most of the trials have been in women, not in 9 to 13 years. That is extrapolated data from elder women. And 9 to 13 years, we will come to it. Some trials were attempted in 2009. There were certain misadventures. We'll discuss about it because that is important. That is documented. That is important. We have to consider those trials. We cannot wish them away and rush for this program. And cervical cancer may take decades, as we have seen. So no trial has followed up to that level. Then measurements biases were in the trials. I have given the reference in the paper by Rees et al. I will give in the end. This I have just given 4 important references. Everybody should go through that and decide for oneself. How strong is the evidence, or what are the gaps in evidence? Published numbers from randomized controls may overstate efficacy because testing during the trial they test very frequently, and there is clearance of lesions. As I said, natural history, most of the lesions clear by themselves. So once you are doing a trial and you are observing that particular point, you will attribute the efficacy to the vaccine. That is one thing. Then trial use surrogate outcomes, like some of which are HPV infection or CIN1, cervical epithelial neoplasm stage 1, more frequently and are very unlikely to progress to cancer. 99% they clear. And some of the trials have done the antibody titer, which like the uh, Serum Institute had produced the vaccine Servavac, they have just compared it with the Gardasil and they have just seen the equivalent antibody response. They have not done anything else. They just say, yes, they are equal to this vaccine. And there were only two groups, the Gardasil group and the Servavac group. There was no actual control group, that is the placebo group. And therefore, the side effects are very difficult to decide because both the groups had 1% serious adverse events. I am just telling you, it is in the paper. Subgroups were overanalyzed. Then there are selection biases as a limited relevance for real world settings because the actual trials in other countries have been done in older women, not in teenagers, older than the target population. Then we do not have, in our country, they tried it in younger, in girls, which had some misadventures. We will discuss about it. Then we do not have enough data on the benefits in women who may have been exposed to HPV before they were vaccinated and who do not know the HPV status. Then 9 to 13 is a good concept because as they say ki once the person has got HPV infection, the vaccine efficacy goes down. So I don't understand why they are promoting it for elderly women up to 35, 45, they say. It is, that doesn't make sense. Then, as I said, surrogate outcomes are measured. We do not have enough data on the impact of vaccine on this CIN3, which is more likely. That is 12%. More likely means 12% of CIN3. 88% them also will clear to progress to cervical cancer. We also have less data on the impact on cervical cancer due to any HPV type rather than just lesions due to HPV 16 and 18. Now they are saying 11 and 6 also. So there have been, as I 150 to 200 strains are there. Other strains, like some strains are also carcinogenic, like strain 58 have been shown to come up after vaccination. Then another important thing is that it does not eliminate the final common pathway for prevention, that is cervical cancer screening. So they, in countries they have done some studies, they found the where the screening is in place, this does not offer an extra advantage. I mean, it's not like that ki you have got HPV vaccine, now you will not have cancer. You have to still go for care because there are 200 strains. And then, of course, there are other STDs. There is HIV, there is sexually transmitted disease, there is gonorrhea, there is syphilis. All have the increase the risk of any malignancy. You cannot tell your children 9 to 13 ki now you have taken SPV, now you can have unsafe sex. You will still, the final pathway is safe sex, behavioral changes, use of condom, use of barrier contraception. It will prevent against all sexually transmitted diseases. So you cannot tackle a problem piecemeal. And that too for a vaccine which has got so many gaps in the evidence. There are more oncogenic types than covered by the HPV vaccine. We are only covering 4 types. There may be 100, there may be, actually there are 200 serotypes, but there have been, two have been associated, 16 and 18, and two more, 6 and 11. So we have got quadrivalent Cervavac at present, but we are still leaving out more than 150 strains. So there is again evidence that cervical cancer screening reduces the risk of death irrespective of vaccination status. The number of cervical cancer deaths have reduced drastically in 3 decades before vaccine rollout. So this has to be baseline data is already, you cannot claim, that is unfair to claim that vaccine has brought down when it is coming down naturally. I mean, we are a poor country. We have to see other health priorities. Long-term efficacy and side effects are unknown. Information from trials can tell us whether between 5 9 after vaccination. We do not know protection wanes after this time. Recent observation studies provide, as I said, some evidence of efficacy of CA3 in goal vaccinated before sexual debut. Ongoing observational studies may tell us about the long-term effect on rates of cervical cancer, but it will take many years before we have the evidence. And that is why I have some reservations. I am just being a devil's advocate. Because as a scientist, we should see the hard data. We cannot use film stars and dancers and singers to just promote a vaccine. That is propaganda. That is not science. That is not evidence-based medicine. Some starlet is feigning death and then reappearing after 3 days. All those things are very frivolous. And science should be serious, and science should be based on evidence. So ongoing observational studies, that is the reason, like once we don't have a long-term studies for 2 to 3 to 4 decades, having going for universal immunization program will eliminate the control group. You won't have a control group. So it would be very difficult. We will never know the answers, and the program will go on and on and on at a huge cost to the exchequer. So we have to be very sure shot of the evidence before we roll out with so much propaganda and hype. Then this is again very important. The Indian experience. I will give the references that all the data, all the papers are in the public domain. The inquiry is also in the public domain. HPV vaccine trials among adolescent tribal girls undertaken in a low-key manner in 2009. PATH, it was the Gates Foundation, conducted the trials in Andhra Pradesh and Gujarat in July 2009 to October 2010. It was described as an observational study instead of a clinical trial to circumvent thorny ethical issues. So this was an unethical trial. Imagine an ICMR was also associated with this PATH Foundation, and 7 girls died during the trial. The sample was 23,000 girls. So imagine 7 girls, young girls, 9 to 13 years, died during the trials after getting the jab. 7 out of 23,000. Isn't it a big amount? Whereas the cancer rate of cervical cancer is death 9 per 1 lakh at 50 years plus, and young girls. So this is quite a pretty figure which we have to keep in mind, and we have to follow up this trial of results of this trial. These 23,000 girls have been given. What is their fate now? What about subsequent? Where is the data? We should ask for that, because that can give us some evidence. Then already the 14 years have occurred since the trial. So we follow those girls and compare it with the unvaccinated. We will know the protection also, the comparison of adverse events also. So why we have closed that file? And this it submitted the tragedy was investigated because earlier they passed it off as coincidental. Imagine, during a trial there is proper monitoring surveillance under trial conditions. There are 7 deaths and they have passed it off as coincidental. The Gates Foundation and the ICMR, and then there was a big public hue and cry. The media took it up also. You can just Google search, you will find the media. Those time media was quite active. Now media keeps silent. I don't know why. And then there was a joint parliamentary committee investigation, and the report was tabled. 72nd report. You can do the web search and find this report in toto. It was tabled in both houses of Parliament, Rajya Sabha and Lok Sabha, August 30, 2013. And it indicted the Gates Foundation and ICMR for irregularities and unethical trials. What happened after that? After that, the trial which they have done to clear the Serum Institute vaccine is a comparative study, non-inferiority study, that their same Gardasil vaccine which has caused the death. The Serum Institute is just establishing that it is same as non-inferiority. It is same as here. And they have compared and they have found 1% serious adverse events among this time 2,500 girls. Here they did 23,000. They just did a trial on a much smaller sample, 2,500, and they found 1% at serious adverse events in both. I will give a paper. One can see for oneself. In both the groups. Both the groups mean one was a Gardasil group, other was the Serum Institute Servavac group. So 1% in both means 1% side effect is quite serious. And they have mentioned serious adverse events. 1 in 100, you can imagine if you give to lakhs of children. And in our country, we do not have proper public health infrastructure. where to monitor the adverse events. So first we should develop a health services all over the country before launching it out to such a vaccine which is unknown, which has caused a misadventure in the past. So, and this is, I was saying, the Sarvavec vaccine, Serum Institute. It contains 1618 and 611. And non-inferiority trial comparing with Gardasil. I have given the reference. I have given just 4 references. Non-inferiority outcome, antibodies. It has just seen antibodies. It has not seen even the CIN1, CIN2. Actually, you have to see minimum CIN3. And just antibodies elicited same as Gardasil. Sample size is 2,307. 1% serious adverse both the groups. And then they said no adverse events were similar in intervention, and people will think control group was placebo. No, control group was Gardasil vaccine. That is also HPV vaccine. So that means both Gardasil vaccine and the Sarvavac both have got 1% serious adverse events. It's given in the paper. I mean, that's why I was surprised ki why with a serious adverse of 1% you are giving vaccine for to 9 to 13-year girls, which to prevent a cancer, we don't know how much it will prevent when the girl is 50 years old. And you are giving on the UIP mass scale. So these are the recommendations. I mean, whatever I have stated may seem very much out of tune with whatever the consensus is going nowadays. But that's why whatever I have given the references in the end. You can cross-check. It's all in the public domain. And then the people can decide for themselves. Doctors can decide better. So we should have a national baseline data on cancer incidence. As I said, the rates, according to BMC Public Health, the rates have come down drastically in the past 3 decades. Mortality and HPV subtype prevalence. These baseline studies, fundamental studies should be done before, if you really want to practice evidence-based public health. This will decide whether vaccine will be cost-effective and should be a priority. Then ensure cancer surveillance and registration are in place before any mass rollover. Then only you will know what is the impact. Initiate national long-term efficacy and effectiveness studies free from industry funding. And I would I suggest, I have not written here, again, I have already said, we should retrieve the data, we should identify those girls, 23,000 who have taken the vaccine in 2009, 7 had died that time only. What happened to the other remaining 23,000 girls? What have been the subsequent adverse events, if any, or then we can make this cohort and follow them up. We have already got a lead of 10 years, 15 years lead we have got. We have to go to minimum 30 years to find the end point. So we have already got a lead 15. Use them as a cohort. And let the HPV vaccine be in the market. Whoever wants to take it, personal choice. High risk group may take it, or anyone can take it. And then takers and non-takers, they can have a control group for a long observational study. But if you give it in the UIP, you are eliminating the evidence of efficacy. And adverse events following immunization, and particular for vaccine which killed 7 girls out of 23,000. And here you will be giving to crores of young people. And then difficult to identify. These are the references. Just go through them. First is the REES, that is Vaccine Prevents Cervical Cancer. This is published in Journal of Royal Society of Medicine. It is an independent study. None of the authors have received any funding from any pharma. So this study has got that importance. And most of the things which I have mentioned has been taken from this study. Very good logic they have given. They have analyzed all the trials. Then other studies on the trends, that is the past 3 decades, how the cases of cervical cancer incidence and mortality has come down. This is BMC Public Health. BMC Cancer, published in 2019 BMC Cancer. Then this is an important paper, third one, Sarojini et al. Trials and Tribulations and expose of HPV vaccine trials by 72nd Parliamentary Standing Committee report. This has been published in Indian Journal of Medical Ethics in 2016. And the Joint Parliamentary Committee report is also available. And this is a commentary on that, the main points. 2 legal experts have discussed it. It's also a peer reviewed. All the four papers are peer reviewed and highly reputable journal. Last is Sarma et al. This is the trial which has been done and published in Lancet Oncology, Serum Institute vaccine, Servavac. And you will find that in this only they have mentioned, this only they have mentioned that 1% serious adverse events in both the intervention and control group. Control group was also having HPV vaccine. Intervention was also having HPV vaccine, different brands. So 1% adverse events across the board, that means serious adverse events. They have mentioned serious adverse events. I was surprised how it is like that. How we have cleared a vaccine and which had a bad history in the past. So I would like the advisors, the experts, the gynecologists, the pediatricians to study these four papers. That's why I have not cluttered it with references, just to show erudition and review of literature. These four papers are standing out like a sore thumb. So this is all I think I have said. I am most welcome to take any questions.
Thank you so much, sir, for your clear and insightful presentation, and your expertise and practical perspectives on this topic has greatly enriched today's session.
Thank you.
So